right, thank you everyone for joining us today. Our webinar is presented in conjunction with NextGen Healthcare. Today we'll be talking about, so you decided to enter MSSP risk-based contracts, now what? So I'll go over a couple of housekeeping items before we get started. Our webinar will be about 30 minutes for the content portion, and then we'll have 15 minutes of Q&A where you can ask all the questions that you have that come up during the webinar. All attendees will be muted during the webinar, so if there is something that you would like to ask outside of a question about the content, you can use the Zoom webinar chat. To submit a question, we'll have a Q&A session at the end of the webinar. You can submit questions at any time using that Q&A box that the red arrow is pointing to on the screen. We'll answer those questions as they come in our queue, and we'll answer them live for you today. And at the end of the webinar, we will email the presentation to all attendees. So look for an email from us this afternoon. And we'll also include a survey link in there. So if you could take the survey and let us know how we did today, we would greatly appreciate it. And then we'll hope you will join us for our next monthly webinar, which is Leadership in the Law, Driving Quality and Value in Clinical Integration on June 13th at 11:30 a.m. Central. We are Lumina Health Partners. We're your partner on the journey to value. We are recognized industry leaders who assist healthcare providers in optimizing their strategic direction, financial outcomes, and operating performance. And these are our advisory services, value-based strategy, digital innovation and analytics, clinical transformation, and leadership and governance. And today our topic falls under value-based strategy. Today's presenters are Daniel Marino, Managing Partner for Lumina Health Partners, and Dr. Betty Rabinowitz, Chief Medical Officer for NextGen Healthcare. So welcome to both of you, and I will hand it off to Dan.
Great, thank you, Lisa. Hello, everybody. Thank you so much for joining today's webinar. We're really excited about the topic today, especially as organizations are starting to move into the new pathways to success and even taking on other risk-based contracts. The topics that Dr. Rabinowitz and I are going to talk about are really important on driving a lot of that success. So we're going to spend a couple minutes talking about some of the industry overviews and why are we moving into this point, and then really kind of dive deep into how to prepare for risk, and in particular, how to optimize the contract, both financially, operationally, and from a clinical outcomes perspective, and then of course, driving that value to our patients. Betty and I will also talk about some of the population health capabilities that are going to be important, particularly around the data and the information that are required to drive a lot of operational insights. So real quick, we continue to see this conflicting paradigms that are occurring within healthcare. Most of the reimbursement still is very fee-for-service driven, but we are seeing, more and more contracts, more and more reimbursement shifting to value-based care. And obviously with what the government has done with the new pathways to success follows that trend. Many of the commercial carriers are also moving in that direction. We are starting to see nationally that a lot of the commercial reimbursement is either staying flat or there's a slight increase, particularly for PCPs, but it's only in the range of 2 to 3%. We're seeing specialists decrease in the reimbursement somewhere between 5 to 10%, depending upon what the markets are. So there's a lot of pressures right now for providers, particularly providers who are affiliated with health systems or even large market specialty groups, to start to think about how they can position themselves well within value-based care, and in particular, well and successfully within risk-based contracts. There is an opportunity to start to create different revenue streams, as we'll talk about in a second, that is really built around the success of these value-based contracts. Providers who are starting to identify their roadmap and how to build these capabilities will be in the best position to start to assume risk, and in particular, have more informed conversations with their carriers and payers and so forth. So real quick, I'm not going to spend too much time on this, but I wanted to give a quick little overview of the Pathways program. There's a lot more detail here. If you need more information on that, please send us a note. We'll be happy to provide more information. But at a high level, there's a basic and enhanced track. There are 5 levels. It goes from level A to level E. There is an opportunity for ACOs to actually start this July 1st of 2019. You would have had to gone through the whole application process, so that now the next real application process with the NOI, I think, goes out sometime around the end of June, somewhere around the 22nd or 24th, something like that. And that would be for a January 1st, 2020 start date. So on the basic tracks, you can see that, the way that the new pathways, the CMMI has structured this, it's really to start to look at all the different programs that are out there and condense those into, a single program, allowing for opportunities as organizations build their capabilities to assume risk. There is a greater upside, as well as then there is a potential downside component of it. So the upside opportunity actually can be quite large when you start to think around the economics coming out of the program. It really does start with understanding the shared savings. And if you're in level A and level B, you have an opportunity to share in 40% of that, that savings opportunity. And then, of course, it goes up to 50%. And if you're in the enhanced track, it's up to 75%. So there is considerable amount of dollars that are attributed to that. But then, of course, there is some downside as well, too. For those ACOs who are considered inexperienced, they would not have to participate in downside risk for the first couple of years. It would be upside only. And then as you move from level A to level B to level C, in level C is where you start to assume a level of downside risk. But the good thing is that it is capped. And you can see that as the levels increase, not only does your shared savings opportunity increase, but your downside risk increases as well. The other area that I want to point out, and this is an important component as you start to think about the economics of the program, the MIPS payment that providers would be eligible for also does increase over time. So when they move into, from level A to level D and then into level E, there is an advanced APM, so the payment becomes a little bit higher. And when you start to think about the economics and what the value is of the overall program, that really does need to be figured in as you think about how to support your providers in the ACO, in total. So as organizations are starting to prepare for risk, we often find, leaders asking some really key questions and helping them to understand how they can remain financially successful or how they can be successful. And the first is, how do they know when they're ready for risk? This is probably the number one question we get asked. With all the pressures that are being placed on providers, from not only the government, but commercial carriers, how do they know when they're ready? The second question is, how do they know, how can they start to bend the cost curve? I was speaking to one of our clients who was in track 1 for a number of years. And for the first 2 of the 3 years that they were in the program, they really did well on their quality outcomes, but they were not able to bend the cost curve. They were not able to show cost savings, and it obviously became very frustrating to them. And so then their question to me was, well, as we're moving into these new contracts, how could we be assured that we're focusing on the right area? And that's really what it comes down to, and we'll talk about that in a second. But it really comes down to understanding where you could put your resources. So the last couple of questions I think are also really important. If you're going to do this and really be successful in a risk-based environment, it is a collaborative, cooperative approach. Physicians have to be aligned with the hospitals, and you have to be aligned with your payer, and you also have to begin to align your patients. If all 4 of those areas come together, you then to start to position yourself well for opportunities for success, particularly financial as well as clinical success. So once you really decide to move forward with the ACO, this is where the real work comes down. And when we start to look at where organizations have been successful in their risk-based contracts, whether it be the ACO or commercial contracts, it really comes down to 4 areas. One, it's truly understanding the data and the drivers of that data, and really being able to create what we call action-oriented operational insights that helps understand where you can put your resources. It helps to put in place and help support some of the programs as you begin to focus on different cohorts of your population. And we'll talk about that in a second, but there is a very prescribed blueprint for success as you start to think about managing not just the high-risk population, but that rising risk population. The second area that becomes pretty important is focusing on or engaging the providers. having the right level of provider participation. And let's face it, this is difficult for providers, especially if you've had physicians who have really only worked in a fee-for-service environment for years. It's the only thing they know. So as you're going through that transformation, the data, the information, helping them, understand areas that, changes in their clinical workflow, helping them understand where they need to be successful in this new value-based care arena really does become important. And obviously you need to have the right level of incentives put in place to ensure that success. The third area is really quantifying the value of these value-based contracts. There's a lot of investment that has to occur. There's a lot of program development that has to occur. There's a lot of cost. So as you start to think about what that ROI is, understanding and being able to translate appropriately is important. And then, of course, the last one, building a very focus-driven care management program is really a key to success. Care management is the #1 driver that will help you achieve success on any of these contracts. So when we look at the successful arrangements, really the driver or the elements that are important, it begins with understanding the cost of care, understanding the different, what the medical spend is, in particular on different cohorts. So your rising risk population, your high risk population, and then also understanding the risk elements associated with that. Risk stratifying and risk adjusting your population helps you understand where to start. Another component is, of course, how patients are being attributed, both in terms of to the provider or to the practice, and then versus how the payer sees that attribution occurring. It is never the same, right, for a number of different reasons. So understanding how that attribution works out is important. The quality measures and the care management also become critical. Data sharing, as well as then understanding that calculation of shared savings, kind of is what really ties a lot of those elements around the success of the contract. So at the end of the day, as we've talked about, the data has to be transformed into information, as well as then really create some strong knowledge. And as my colleague once said, that knowledge has to be translated or transformed into wisdom. So we are really able to make some key results. So when we talk about where to start, it's important to understand that there is a blueprint that organizations can start to create that helps lead them to that success. And first, it needs to really come down to understanding the elements that are critical in that contractual relationship between the ACO and the payer. Now, for the MSSP, it's pretty much defined. But for commercial contracts, there's a little bit more ambiguity there. So it's important to understand what those contract drivers are. Then you start to begin to build that within a lot of your operations. The governance structure is, of course, critical. Form follows function. So if you don't have the right level of governance that helps you interact appropriately with your physicians, with the care management team, with the finance team, then you're at a disadvantage because you're not going to be able to align all the appropriate activities across the whole network. So the governance becomes really important and is a key factor for success. Of course, your provider network is critical as well too. What we often see is as providers start to come together, they usually do a good job of managing care within the network. But understanding how to maintain that activity of care within the network becomes a critical factor for success. As patients leave the network and choose to get care elsewhere, their opportunity to really influence that quality and manage the costs goes down dramatically. So being able to understand elements of that network, particularly around how post-acute comes into play, your tertiary care partner, and so forth, is important. And then care management, obviously we've talked about that before, and I'll talk about that more in a second. But it really, in our opinion, does come down to how you deliver a lot of the key information and be able to present that appropriately to the audience that you're working through, whether that would be the finance folks, the physicians, your care managers, or even the payers. That does feed a lot of your communication and your education as well. So let's break down for a second that blueprint as we talked about and begin to talk about where that area of focus is. So when you think about the cohorts of your population that you're assuming, 5% typically of that population is considered high risk. And these are the sick of the sick. And let's face it, these are the patients that really do need the care. So you're not going to restrict the care because they need it. What you are going to create is opportunities for efficiency, and you'll get some cost savings out of that. But the key to understanding, or at least the key to the success of a risk-based contract, is understanding the rising risk population. What are the elements that go into that rising risk population? How do we start to get ahead of that from a care management and a care intervention perspective? And then how do you start to prospectively manage these patients? Care management, as we've talked about, really becomes key. So as you start to understand aspects of those cohorts of the population, you then can specifically design programs that helps to manage the patients and helps to direct the patients in a way that provides a clinical outcome opportunity as well as a financial medical spend opportunity. And we typically see these in 4 areas: obviously continuing to manage the rising risk population, but also understanding that those patients who are considered in need of complex care. Disease management and preventative health also come into play. So if you could start to understand aspects of that rising risk population, and so for instance, if you understand that, if you're able to identify, let's say, patients with CHF are contributing to a readmission at a hospital and also high utilization of your emergency department, you can start to put in place programs that helps to manage those patients. So it does really come down to understanding the analytics and thinking about it in such a way that helps you to report it in a way that physicians and your leaders can actually take action on it. Beginning to think about advanced reporting, so you can start to do a level of modeling that helps you prospectively manage these populations, and then having it very action-oriented, where it translates well into some of the clinical workflows and care management and so on and so forth. So with that said, I'm going to turn this over to Betty and give Betty an opportunity to talk a little bit about some of the action-oriented analytics that she's been very successful with her team. Betty?
Thank you, Dan. Glad to be here. And the focus of my portion today is really to look at the ways in which data and analytics support the organization through this transition into a value-based contract. The 3 areas where data is foundational or crucial are obviously measurement of quality and performance, which is a key component of each and every one of these contracts. The second is population health, which is the term is being used broadly here, but really focuses on the ability to identify cohorts of patients with common denominators in order to learn about them or apply interventions to them and measure those interventions. And finally, Dan reflected on this, cost efficiency is critical, and there are significant needs around measurement of real-time costs and spend and variation in cost and spend that allow you to begin getting control over costs within a given contract. The first element of a successful foundation of data-driven organization is recognizing that the days in which a feed from an electronic health record was sufficient are long gone, and that in order to be successful, one has to create an infrastructure that allows integration of multiple data sources. First and foremost, many of you find yourselves in organizations that have multiple EMRs and probably are predicted to remain in a multi-EMR environment for quite a while. Even though the focus of the conversation today is on MSSP programs, commercial programs will have adjudicated claims as well as the MSSP adjudicated claims, and those need to be integrated. The importance of social determinant of health is beginning to come into clear focus now, and the ability to integrate information from clinical and non-clinical sources that pertain to social determinants is becoming more important. And in many of your regions, there are health information exchanges, HIEs, that have done a pretty good job in most cases integrating data from multiple hospitals where your patients are being served and other healthcare organizations in your area. So integrating HIE data, even for something as simple as ADT flows, so that you know which patients are being admitted, discharged, transferred is extremely important. So the ability to create a rich tapestry of multi-source data cannot be overestimated, and the challenges that this brings forward can't be underestimated as well. It requires basic foundational capabilities on behalf of the analytics platform that you're using, but it also introduces complexities in terms of analyzing the information, because it's a tapestry of truths. And it's very interesting to watch the struggles organizations have coming to terms with where the truth lies and what the golden record is and how all of this information is integrated. So we see this as one of the first challenges, but once this is overcome, really an important one. Dan referred to the importance of attribution, both at the provider side and the patient side. It's quite fascinating to watch the complexity and the intricacies of differences in attribution. And physicians have a very linear view of attribution. They either had a paper record for the patient and knew them and had seen them, or the patient wasn't theirs. And we know that the truth now is so much more complicated. EMRs attribute patients in certain ways, depending on the way EMRs are implemented. There could be skeletons in those closets that come to haunt you because there has not been good attribution done at the EMR level. So even that can be complicated. HIEs and hospital attribution can vary. There could be distinct keys attached to patients, which are different and disparate from MRNs, and definitely disparate from contract numbers from the payers. So the ability to both integrate this data so that John Smith in 4 different systems ends up being one person and it's the same person. So an EMPI capability is extremely important, but also conceptually coming to terms with the challenges of attribution and deciding which attribution in which context trumps the view that you're going to show your care teams or your leadership team or the physicians to create the most actionable insights and data. And one has to come to terms with the fact that there will be different parts of a robust population health platform in which different attributions can be allowed, and the system needs to be able to flow quite fluidly between them. Quality measurement has been around for a significant part of our careers. There are now points of wisdom that we have developed around quality measurement. It's clear that participation of all team members, I always say, quality is a team sport. So if you're not involving nurse practitioners and PAs and your providers and the administrative teams and clinical teams in the practices, you are losing out on opportunity for success. The notion that clinical teams and physicians can focus on more than 10 to 12 measures at any given moment is probably a fantasy. And even in programs where, for example, in MSSP, the measurement is much more than 10 or 12 measures, try and expose those in portions or in measure. It's very easy to overwhelm clinical teams. And it's important to design measures, take into consideration workflow, data capture, and clearly it's not all about measurement if you don't have a workflow that supports capturing the data or entering the data in a way that's usable. And this is best done before you publish a metric and agree to be measured on it as part of the contract. And finally, if your organization is going to be entering in multiple programs, it's so important to spend some negotiation coupons, so to speak, on trying to create parity or similarity between the programs so that you're not creating a completely complex tapestry of measures that physicians can't handle. to have some clinical sense and clinical relevance to the measures you're choosing to focus on. Physicians relate to that much more positively. We recommend a measure du jour or measure the month, where across the organization there's an effort focused at a single measure or a couple measures, so that the workflows around them and the measurement can improve and get better. The only good news around measurement, in my mind as a clinician, is that eventually it's all going to be about outcomes. We're trying to get there, remembering that actually what's important is changing the way we practice rather than just studying for the test is important, because eventually that part of measurement will catch up with us. It's important to have a cohort of team members within the organization who know your data well, who are expert Sherpas to the data that can help both the analytics vendor that you choose, but also help translate the data and its analytics to care teams. And it's extremely important to remember that even though audits happen infrequently, it's extremely important to always remember that there needs to be a trail of evidence. It doesn't help to take shortcuts on the way to quality measurement if those don't allow you to pass an audit. Cost efficiency, clearly important. The game at the end of it will be about identifying low-value care. Clearly, of the $3 trillion or so we spend in this country a year on healthcare, probably $1 trillion, a third of those costs are generated by low-value care that isn't changing outcomes or improving quality of life. And the way to identify low-value care, one of the mechanisms is to identify unwarranted variation, which identifies under, over, or misutilization. And once you've identified areas that are generating low-value care, you identify the variation in the way providers are generating that care. That gives you the beginning of access to begin to change that. And it's important to remember that not all care costs can be controlled or controlled easily. And it's important to start with those that can. My time at the University of Rochester focused initially on high-cost medications in multiple sclerosis, and we found very quickly that even though highly expensive, there was a significant amount of variation in the way folks were beginning those medications. There was very little tolerance to changing practice patterns around it, because it's a devastating disease in young women usually, and it wasn't a good place to focus efforts. Much more important to focus efforts where there's both variation, generation of low-value care, and opportunity to change workflows. And that really speaks to the element of impactability. It's very important to remember that when you have cost and utilization data, one of the things we watch organizations doing is getting very caught up in trying to reconcile the exact numbers that are generated internally with external reporting around cost. And it's a very difficult exercise to do. The equations around IBNR and run out are very different. It's important to reach a point of stability in the two types of measurement, but not necessarily chase parity and equity, as long as the insights you have allow you to change behavior and identify areas to do so. And lastly, it's really important to generate a view for the physicians that speaks to them in terms of both cost and quality. If you report to physicians separately about cost and separately about quality, usually what physicians will say when you tell them that they're producing high-cost care, they will say that their quality is very high. That's the reason, and vice versa. And we know that the correlation between cost and quality is not a very tight one. So identifying a way to report, and I'll show you in a moment an example of it, report on cost and quality together, very important. There is a lot of interest and focus on benchmarking. It has pros and cons. Sometimes it's better to use internal benchmarks and comparisons so that you make sure that you're moving ahead. And if you're using benchmarks, regional differences are extremely present, and it's important to have access to regional benchmarks rather than just comparison to national benchmarks. This is just an example of a integration of cost and quality. We create basically a fusion view between cost and quality. The y-axis has a weighted average of quality measures. The x-axis has risk-adjusted cost per member per month. Each of these dots reflects a physician, and obviously where you want your physicians to be is in this left upper quadrant. And as you go into these risk contracts, having this type of view of the universe that allows you as the medical director to go and visit the person here generating very high cost care at a very poor quality, or this person here generating relatively inexpensive care but very poor care. Those two folks need to be kind of remediated, and best practices need to be disseminated from the rest of the group. This is just another example of identifying practice pattern variation around emergency room treat and release. Again, risk-adjusted information. Here are practices at the end of the graph, outliers who are utilizing many treat and release visits compared with risk-adjusted colleagues in their organization, and starting these conversations and understanding the variation is the beginning of the road to changing this behavior. Population health is truly a set of tools and an approach and a team-based approach to allocating scarce resources to patients who need them most and will impact your performance both from a quality perspective and cost perspective most. HCCs are the coin of the realm in an MSSP contract. I must say that those of you who have worked quite a bit with HCCs, I find them useful, obviously, because they are the coin of the realm, but quite lacking when you try to apply them to a broader age group or overall populations. But getting to measure HCCs well and bringing to the point of care the gaps in HCCs is critical, because it obviously determines financial success in many of these advanced practice models. But it's important to remember that HCCs is one view risk and is extremely narrowly focused on a single cohort in your population, and that having the ability to apply multiple risk algorithms is very important, and using different risk algorithms rounds out the differences in terms of age relevance and similar differences between these risk algorithms. Social determinants of health are going to become more and more important over the next couple of years in adding another dimension to our currently mainly cost and clinically driven risk algorithms, because they very powerfully speak to impactability and add another dimension to our understanding of what needs to be done for specific populations. This is just an example of HCC risk stratification of a specific provider with 130 patients. 1% of those patients are very high risk. 46% of those patients are patients who have not had appropriate coding done. So these zebra lines identify for the group at the population level opportunity for HCC risk closure. And then at the point of care, this particular system is able to expose color-coordinated diagnoses for drop-offs. And bringing this information to the point of care is essential because it allows intervention at the time of the visit so the physicians can assess, document, and code for the particular HCC drop-offs. No point in knowing a lot about HCCs unless you can bring it to the point of care, single sign-on in the context of the visit. And it's incredibly important to integrate all of these insights at the point of care, both HCC gaps, but also a lot of the risk stratification and views of quality and gaps in care. This is just a final example of a EMR patient banner that has a lot of information about risk score, gaps, past due gaps, gaps that are meeting performance, that allow exposing all of this information, single sign-on at the point of care for clinicians. I am going to end just by saying that if you want to create value, don't pay for volume. When I was the medical director at the Center for Primary Care at the University of Rochester, we found that until we created about a 15% shift in physicians, this was a large employed network, in physicians' compensation to value, we were unable to truly engage a very busy, very beleaguered, very burdened group of physicians. Once we got to about 15% of their compensation tied to value, we saw a shift in behaviors, in engagement, and in interest. In my travels, I see groups completely disappointed with their physicians, even though the behavior is completely predictable. If you pay fee-for-service and solely fee-for-service, it's very difficult to change behaviors around incorporation of value. And really just a last plug here to say this is a team-based approach, and incentives need to be aligned across the team, not only physicians and nurse practitioners and PAs. Going to return to Dan, and I think we'll have the Q&A session now.
Great, thanks, Betty. Yes, I'll take the reins back here. So a couple of comments. I really like the way that you talked about how you can use HCCs and how HCCs through some risk scoring, being able to drive that down to the providers, you really can make some nice impact, and at least really being able to integrate that into the workflow. That is such a critical element there. Lisa, let me turn that over to you. Are any questions from the audience that Dr. Benowitz and I may be able to answer?
And our first question is, how do you create the right incentives with physicians and hospitals?
I can start this one, and then I'll turn it over to Betty as well. I think when you start to look at the incentives, it really does start to evolve as your risk-based contract, your arrangement with your payers, and the maturity of your ACO start to evolve. Right off the bat, though, there's going to be a lot of work that is going to be expected from primary care. And as we talked about, it is a paradigm shift that we're asking our physicians to undertake, especially if the only thing they know is really working in the fee-for-service environment. To transform them into fee-for-value will kind of disrupt their normal way of practicing. So we feel it's important to really provide a strong incentive to primary care physicians. Plus, if you look at where the program starts to really launch, it's very primary care focused in terms of the attribution, in terms of what the quality outcomes are, and they have a strong influence in really being able to manage and bend the cost curve. So we really do like to focus on primary care, but then making sure that we do leave a portion of dollars for hospitals rather, and for other entities that may be participating in influencing a lot of the outcomes of the ACO. Betty, I don't know if you have any particular outcomes or any thoughts on that
no, absolutely. I agree, Dan, that primary care is truly the kind of the head of the spear on most of these advanced practice models. We've actually seen some places where specialists have chipped in to actually contribute to enhancing primary care compensation pools around participation and success in some of these programs. It's really important to create a culture of trust in the data and analytics, because this really is very different now than just a pay-for-performance program from a local payer. You actually are going to be driving the physician's compensation based on your measurement. And it becomes very iffy if there isn't a stable, trusted source of data in that context. So the stakes are higher.
Yeah, that's a really good point. I agree.
And a question from the audience. I know this is not applicable to MSSP, but for commercial ACOs, how do you incorporate reinsurance requirements?
Yeah, that's a good question. And we do see that a lot of times with the commercial ACOs. It's important to, again, understand the data and really understand what's in and what's out. We feel it's important that providers should be responsible for what they could influence and what they could manage. And, there's really two types of risk out there. There's the performance risk, which providers should be responsible for, but there's also the insurance risk, which are the things that happen as an act of God that you are sometimes out of your control. So what you can start to understand or start to do in your contract is start to segment elements of that insurance risk of your population and kind of put that aside, or start to incorporate other reinsurance requirements around that would allow you to participate in, say, some stop loss insurance or something like that. You really don't want, you want to obviously incorporate that into your relationship, but that should not be the focus of your relationship. You have to plan for that appropriately, but you really want to make sure that you're focusing on the areas that are really going to influence the care, influence the cost curve, and really enhance the quality.
Great. And would you comment on suggested sources of financing preparation for downside risk, including letters of credit, surety bonds, et cetera?
Yeah, that's a good question. When we help organizations think about building reserve requirements, we like to build a multi-source approach in helping them to align that, because what it does is start to align the incentives. So in some cases, we've helped organizations or ACOs create programs where, say, the physicians would be responsible for a very small portion of the downside risk that could be funded from their MIPS payment, which is, as been pointed out earlier, that MIPS payment does begin to increase, but it ties them into that success. Obviously, the hospital funding would be a second element, which we feel is important. We also believe that, a local bank providing a line of credit or a business loan is also a great way to fund that. And then the fourth area would be to get some type of stop loss insurance. So we feel like if you can create that balanced model to help manage the downside risk, it doesn't overly tax any particular area of the ACO, but more importantly, and Betty talked about this, is it really does align the incentives of the providers with the outcomes and the success of the ACO.
Great. And aren't there opportunities for transferring some total cost risk to payers or reinsurers?
Yeah, absolutely. And Betty, I can answer that. I don't know if you have any thoughts on that.
Go ahead, Dan. I have an interesting observation about stop loss, but go ahead, take the question and I'll add.
So there are opportunities to be able to realign or transfer some of those costs. And, again, I always feel like it's important that the ACO or the contracting, provider entity, they should be held responsible for those things that they can control. And, if you've got a series of, let's say, particular areas, some cancer patients, for instance, that are providing a lot of, costs and really do need the care, some of that should be contracted out of your ACO, because you can't really be responsible for it. Those are patients who are sick. They're going to go to a tertiary care facility to get their care done. Where the ACO does become important is in helping to create a level of efficiency of the care that's being delivered, but you're not going to restrict the care. So there is an opportunity to negotiate that out of your contract and potentially shift those costs. But again, the elements as you're starting to negotiate that commercial contract, those are a couple of the key things that you want to look at, as well as aspects of attribution, how that would figure into your medical spend target, how you then begin to reconcile that over time, who's in, let's say, your tier 1 network versus tier 2 and tier 3. That obviously influences how you can transfer some of those costs. If anybody is particularly interested, afterwards send me a note. I'd be happy to send you, some recommended terms that we like to advise organizations on that are really critical to a successful risk-based contract. One of those, as you mentioned, this would be included in there as well.
Dan, I just add around the stop loss that it's interesting to create a staged approach to the level of stop loss coverage that you create, that basically while your care management program is maturing and you have a good sense of what's impactable and not impactable, you start with a more coverage around that risk. And then as you become more confident in your ability to impact those costs that are impactable, you can start creating a higher bar for the stop loss to kick in on. And then, as you said, there's just at the end of the day, very bad things are going to happen to some of your patients over which there is very little control. But there's a whole stage in the middle that allows truly maturing in safety rather than taking on a lot of risk early in the ACO days and having scars from that.
Yeah, that's a great point. And I would even think building onto that, if you start to look at some of your outcomes where you can quantify the effects of your care management, then you have an idea of how much coverage you would need going forward, and you can do a little better planning for it. Plus, you're really validating the success of your care management program.
Great. Well, that's all the questions that we have in our queue. Thank you for all that great insight and information. This is Dan and Betty's information. If you'd like to email them and get in touch with them, feel free to do so. We'd love for you to check us out on luminahp.com. Also follow us on Twitter at luminahp. Follow our Lumina company page at Lumina Health Partners on LinkedIn, and also follow us on YouTube at Lumina Health Partners. And you can also watch our previous webinars on our YouTube channel. We'll also post this one probably within the next week or so. Thank you so much for joining us, and we hope to see you on a future webinar. Thank you again to Betty and Dan, and we hope you have a great afternoon.